Um, Welcome to today's webinar sponsored by Simon's VIP Connect. Thanks for joining us for the question and answer discussion about speech therapy. My name is Bethany Smith-Packard, one of the genetic counselors for Simon's VIP Connect, and I am joined by Jasmine Urquhart, a speech-language pathologist and Executive Director and Chief Clinician at S&L Therapy in Boston. Hopefully you've had a chance to watch Jasmine's presentation on pediatric speech and language services that was posted on our website. Her talk provided some great information about the basics of speech-language pathology services. And today's webinar will give you a chance to ask Jasmine some of your questions. During the discussion, we'll have the phone lines on mute to decrease the background noise, but you can submit your questions in the chat window on the left side of the screen. Today's webinar will be recorded and posted on the website so that you and other family members can watch it in the future. Just one quick housekeeping item before we begin. We want to remind you that the early bird registration for the Simon's VIP Connect family meeting is now open. The early bird registration will be available until April 8th. After that, the cost to register will increase slightly. You can check out the link from our main website for more information about the family meeting, including the agenda and planned activities. So let's go ahead and get started. Our first question that we received by email asked about a son who is 13 years old who had been receiving speech and language services since he was 3 years old. He received both private and school-based services and still has significant speech and language issues, being diagnosed with dysarthria and dyspraxia. He's changed therapists and sought out second opinions several times, and the family is wondering, what do you, Jasmine, recommend for your harder to treat cases?
Yeah, it's a great question, and we do often have families come to us in cases where they have tried other options and have not been successful. I would say that the most important thing that you'll want to consider in terms of therapy moving forward is that motor learning and coordination motor speech acts require a really consistent approach. So once you enroll in therapy, you would like to have consistent attendance and consistent methodologies used to help improve the speech production. Before you even get to treatment in terms of using that consistent approach, it will be really important that you find a speech therapist who's skilled and experienced in working with motor speech disorders. And it's a specialty, a subset within our fields. And so I'd recommend, if you're interested at this point in exploring your options for a speech-language pathologist who might be able to have a really systematic and effective approach with your son, find a speech therapist who's experienced in working with these types of motor speech disorders. One good resource for finding a speech-language pathologist, as I'm describing, would be to go through a local hospital. Here we go through Boston Children's Hospital, and we get referrals from there quite often in cases where parents are looking for a very specific type of therapy and a specific type of approach. So I'd recommend in your area looking for a pediatric-based facility that may be able to give you a reference to a speech-language pathologist who specializes specifically in working on motor speech disorders. So my best recommendation would be to find someone who knows how to treat these types of disorders specifically, and then enroll in a very consistent program that would allow the methodology to be used on a weekly basis in a really consistent manner so that you can be making measurable gains. And we'll be talking a little bit later about measuring progress, but that's an important factor to consider.
Thanks, Jasmine. That's really helpful. Are there any questions based on that answer that anyone has? Okay. We can move on to the next question. Is there an average time that you start to see improvement in children after starting therapy?
That's another good question. The length of therapy or the amount of time it takes to make progress will vary significantly. And some of those factors will be the type of therapy you're doing. So are you addressing a speech disorder or a language disorder, the age of the child, and the rate of progress? I would say at a minimum you're looking at a few weeks, 12 weeks, to begin to see some significant measurable gains. We see changes in children after a handful of sessions, but we typically look to track our progress over a 3-month period. So within 3 months, we expect that we'll be able to demonstrate measurable change in a child's speech or language skills to then move on to another skill within a hierarchy that is more challenging for them. So a good length of time to consider would be about 12 weeks, giving a child a chance to learn a new behavior, whether it's how to get their tongue in a particular position for a sound or how to use certain vocabulary, and then allow them to move towards more independent use without the support of a clinician modeling that word over and over or showing that sound position over and over again, and then allowing them to produce it more spontaneously.
Great, thank you. And is there any difference in starting children younger, at later ages?
Sure. The earlier that you can start, the better. That's kind of the going thought process around intervention, and that's part of the reason why there's so much funding around early intervention programs, is that if you can get in with a child younger, you have the best chance at being able to make changes that can last. They also have greater brain plasticity then, so you're really looking at changing hardwiring for a child in their development. With speech and language specifically, there are some things that will require a child to be a specific age. So if you remember back to when we spoke about speech production and sound acquisition, certain sounds come in at certain ages, so certain sounds are expected at certain ages. And so that would mean that we'd have to wait until a child was beyond that age to say that there was something there that we needed to address. So for example, a child who is 2 or 3 who might have difficulty with R or TH, those are later developing sounds, and so for that particular type of error, we would wait until the child was older, 6 or 7, to even start thinking about addressing that sound in therapy. So age can play a factor in that way too. The same thing applies in language. There are certain language forms and constructions within sentence development in the way that children speak that are developmental, and so there are certain points in time, benchmarks, for when we'd expect those things to develop, and so we wouldn't teach ahead of those benchmarks. We'd wait for those benchmarks to pass before we said that it was something that we'd need to address within therapy. In general, like I said in the beginning, the younger the child is, the better. And for motor speech specifically, you'll find that for many older children, so by older I mean in elementary school and beyond, if they're working on motor planning and sequencing, the longer that they've been doing a pattern that's not what we're looking for, the longer it takes to kind of undo that pattern and teach something new. So I would say that there's never a time when it's too late for therapy within the pediatric realm, but I do think that you do see faster progress, and I do see faster progress with children when they're younger than as they get older. One advantage of older children who are working on speech, which does tend to work very well in their favor, is that they tend to be able to understand or conceptualize directions and have a better awareness of what they need to do in therapy sessions. So for speech specifically, older children tend to be able to really volitionally make changes to their articulators, where younger children need a much more play-based approach and may need a great deal of shaping to get their tongue and teeth and mouth in the right positioning to get those new sounds out or to have them produce a new language form. So there are pluses and minuses to every age range. In general, the thought is an intervention that the younger the child is, the better. But there are cases where we do have to wait for development to run its course before we can start working on something. And there, again, are advantages to working with older children as well.
I know you had mentioned that in a therapy session you typically like to have a set amount of time to be able to get the child comfortable and really start working on the techniques. Is there a typical length of the therapy as far as how long you work with the child, how often, and does that frequency matter?
So Yes, it does matter. The length of the actual therapy session does tend to vary. As I said in the presentation, in school systems we find that it varies anywhere between 15 minutes up through 45 minutes per session. Here at our practice in Brookline, we provide sessions that are just under an hour. We find that that's a really appropriate length of time for most children. From the preschool age range up through middle school, they're able to attend and participate in therapy sessions of that length. It gives us enough time for them to settle into the session and also actively participate in therapeutic activities. In terms of how often a therapy session is provided, that also varies depending on a diagnosis. So we would say at a minimum a child should be in therapy once weekly. I find that if a child's in therapy less often than once weekly, it's not really a therapeutic model. Instead, it's more of a monitoring type of a format where you're checking to see how they're producing different things, but it's tricky to make measurable changes without seeing them on a consistent basis. There's a relationship that needs to develop. There's a routine to what you're doing within the therapy sessions, and all that needs to be established and maintained in a weekly relationship and appointment with a speech-language pathologist. So at a minimum once a week. In general, the more therapy sessions per week, the faster the progress, but there are a number of variables that will play into that are really child-specific in terms of how much change we expect a child to make within, again, that 3-month window of time that we would be setting our goals and objectives for each child.
Great, thanks. And could you give an example of what a therapy activity might look like in a session? I know you had discussed the clinician-directed versus child-directed.
Sure. So for a child who's working on articulation or even motor speech, we need the child to be really focused on their articulators, on how they're moving them to produce a particular sound. And so what I tend to move towards is having a child follow my direction a bit more and be sitting at a tabletop or sitting across from me in a way that we can both be attending to each other and engaging in a joint task. So for articulation, for example, if I was trying to have a child produce a particular sound like F, for example, I would have provide models and cues, whatever level of support they needed to be able to successfully produce the sound, and give them many opportunities to try and establish that articulatory posture of having their teeth come down over their lips. This is for F, for example, but it could be for anything. And then after that, giving them opportunities to attempt to produce it correctly. For a child who might not be producing that sound, it may take a bit of experimentation, and that's great. We want a child to be able to try something out and see how it works, and if it doesn't work, that's fine. Have them try again. But it's within a more structured context where I can model something and I can have their full attention and then allow them to experiment and explore that we eventually meet success when they're able to produce and establish that articulatory posture. So with that being my goal for a child, especially a young child, we still need to have some kind of game or something fun to do. It's no fun to just sit there and look at me producing an F sound. And so what we'll do is we'll play a board game, for example, and have the child move along the board game as they're attempting to produce the particular sound. Or we might build different animals with Play-Doh while we're sitting at the table establishing that particular sound. And I find, again, it doesn't really matter what the activity is, but the important part is that you have the child's attention and that you're consistently giving them an approach, a support that will allow them to meet success in establishing that articulatory posture over and over again. And that's why the clinician-directed approach tends to be more successful for that type of therapy, especially in the beginning where you're asking a child to do something completely different with their mouth than they're used to doing when they're speaking spontaneously, or they may be out in the playground or speaking with their parents on a car ride. So again, capturing their attention, shifting it to your mouth, and then having them produce the same thing that they're producing. And again, the level of support that you provide, the way that you would elicit it will depend on the particular child, but the idea is in a more clinician-directed approach that you have their full attention, you have a joint activity, but you're shifting and directing how they're participating. And for a more child-directed activity, let's just keep the speech production, even though it may not always be speech production and child-directed, but just to illustrate the point that it really could be anything. It doesn't have to be a completely different skill to shift into a child-directed approach. Let's say the same child, after successfully establishing the position for F, they've been able to produce it at the sound level, so they can go and they can bring their teeth down to their lips and produce that with my model. Then I would systematically fade back my model and my support, whatever it was that we did to establish that success. And then we'd move it into words and then into sentences. And then after the stage where we're working on sentences, I would be looking for them to produce it more spontaneously. So let's say, for example, we've worked on the F sound in isolation. We've worked on it in words like fish and fun and photograph. And now I moved it into sentences. So for example, a child can say, I see a fish, without any difficulty. The more child-directed approach would be for us to set up a fishing activity where I wouldn't have any direct specific speech target words or sentences that I'm trying to elicit, but instead within the activity I would be monitoring their accuracy in the use of words that are embedded within the play. So for example, for fishing, there are lots of great words because fishing obviously starts with F within itself, but maybe we'd find some food for the fish, and then you've got find and you've got food, you've got a fisherman potentially, and there are all other kinds of words that you can add in and kind of sprinkle through your activity where you're not explicitly eliciting the production in that face-to-face interaction that you have in the more clinician-directed approach, but instead as you play this pretend activity, this game, you would be looking to increase their accuracy in the production in a less direct way. So you would follow their lead for how they wanted to fish, and then you would collect data on how they were able to establish that articulatory posture on their own. More often, you find that the child-directed approach is used for language skills, especially as they're moving towards more spontaneous use. So I often, with my younger children, the preschool age range children, will have them complete an activity where there are obligatory opportunities for them to use a particular language form. So for example, I have one child we're working on using the word better instead of more gooder. We're working on is better, and so we're looking more at the grammar there. With this particular child, and this child is 4, I'll ask them questions, and we have this whole game, this or that, and the game is based around which item he likes better. And we might do that, and that's a more structured approach at first, where I'll just be asking him questions that are really pointed. Which one do you like better? Do you like chocolate or vanilla better? Do you like daytime or nighttime better? And then his response is set up in a way, in more of an obligatory context, so that I get the forms that I'm looking for, and I might give him feedback on that particular form as he produces it. But more spontaneously, we might take a trip into our kitchen here in the practice and look for different things we'd like to have. And I might just incidentally say, I think we should use chocolate. I like chocolate better. And again, I'm enticing this child into producing the language, but I'm not directly eliciting it from him. Instead, I'm giving him opportunities to produce it. So then naturally he will respond and say something like, no, I like this one better. This one is better. And so I get my targeted form. So it's an indirect approach, but allows the child to take the lead more often in therapy and get a more naturalistic production.
Great, thanks. Sounds like you try to make it so the child's engaged and having a good time, but still really meeting those markers and milestones that you're looking for.
Absolutely, that's exactly it. The child needs to be engaged. It's one of our top priorities. They need to be having a great time and interested in being in the therapy session. And without that, it's hard to build motivation towards making changes to communication.
Great. And is there a difference with how you approach therapies and activities when you're working with children who might have some autistic-like features?
For every child that we see, we customize a therapy session for them and our approach. So every child's therapy is individualized to their interests, to what other variables they may have in terms of sensory needs or in terms of attention needs. So I would say for every child that we see, we do customize a therapy plan. So there are going to be distinct differences for every diagnosis. For children on the autism spectrum, obviously where social language tends to be a very specific pointed area of need, social language should be included in everything that is being done within the therapy session. So we have children come in who demonstrate autistic characteristics or display autistic characteristics, and within that, even if we're working on something like speech production, we still embed social learning opportunities for them. And then in our social skills groups with children who are diagnosed on the autism spectrum, we give explicit instruction, for example, in social language skills that they may not pick up more naturalistically, and then we give them opportunities to try them out with other children. So for example, in conversation, we might teach them to consider the other child's conversational input when they respond in conversation, and then we'll have a conversation and see how many times that we can try to include a peer's information into the conversational volley back and forth. Or with negotiation, we may explicitly teach, hey, when problems come up, sometimes you need to be able to work it out. We change the wording so that it fits for the children. And we may teach negotiation strategies like, hey, if two children, if you guys can't figure out what you want to do with today, or you don't know which toy you want to play with and you can only play with one, here's some ways that you can problem solve. And we might say, you can try eeny, meeny, miny, mo. We can take a vote and give them some options. And we often also give them visuals to reference these options. And then we provide them with opportunities to use these options. So we often shift our focus from just the outcome, in other words, the game that's selected, to the process that they use in order to get to that outcome. So we would then highlight and reinforce when we're seeing great negotiation strategies or offers of negotiation strategies happening versus the fact that they're playing a particular game. And we look to build social skills that way for the children. So I would say there's going to be a different approach or methodology and different characteristics and aspects to consider for every child. But typically for children diagnosed in the autism spectrum, social language learning is a critical component to include, even if it's not the primary focus of the therapy.
Great, thanks. And looks like just one more question we have right now. Are there any specific questions that families should be asking their speech therapist to make sure they have a good handle on everything that's going on, or anything you would recommend along those lines?
Yes, there's a couple of things that I think are critical to ask a speech-language pathologist, and I get these questions all the time, and I'm always impressed and happy to get them because it just shows me that a parent is really tracking along with what we're doing, and it's a great way to start a dialogue and discussion about those measurable gains. So the first thing I would say is having a very clear description of what the therapy plan is. So every parent should know what their child's working on in therapy, both qualitatively and quantitatively. So qualitatively, that would be, all right, so we're working on improving my child's ability to communicate in such and such a way. So in terms of being able to request information, in terms of being able to develop an oral narrative or tell a story, for example, to be able to have clearer articulation and be more intelligible. So those would be more qualitative types of changes so that it improves their ability to communicate in everyday situations. The underlying component of that is critical and really the building blocks to get to the qualitative changes would be the quantitative changes. So by that, I mean what are the specific measurable goals that are set in order for each child to make those gains. And if you remember, we talked earlier about 3 months being an amount of time that's appropriate to see a child make measurable gains. Within a 3-month window, we typically will set a specific benchmark that we're looking for a child to achieve. So for example, the child earlier who I was mentioning when we were talking about which flavor is better, chocolate or vanilla, we were going into the kitchen and trying out those different flavors, that child might have an objective written that said something like he would use that form, is better over more better, or some other variation that he was using with 90% accuracy over 3 sessions. So every session that I saw him, I'd be tracking his level of accuracy within a particular context. So the question asking that's more direct would be different than when we were out in the kitchen, but in both cases I would be looking for a certain level of proficiency in the use of that particular form. And then after that form is achieved, then I can move on to another form that he might need to be developed into his expressive language. So a clear description of the plan that includes both a qualitative and quantitative component will be really important so that you can measure and track progress along with your speech therapist. And that tracking should be systematic. So on any given day, you should be able to get information about how your child did. And it's great to know that they had a good session and they had a fun time. But in order to really make gains in therapy, you also need to know how accurate they were or how many times they're producing certain words or targets and how that might apply. It also could be really useful to get more information about how you could be carrying over those skills into the home. The only caution I would have is that you'd want to make sure the child has mastered whatever skill they're working on before working on it at home, because it's the job of the therapist in order to establish and to maintain the skill. But once the skill is at a level where you could expect to see it generalized to other situations or other environments, it's wonderful to have parents come on board and also carry over these skills into other activities. So with this same child, again, we're working on this is better. He's also, the plan is that after we finish this more structured component of his therapy, he'll be able to then go home and he'll have some activities where he can practice the same thing with his parents. And one of the things that he's collecting information on now in preparation for that are some of his siblings' preferences. So which one do you think is better? And he'll ask them, and they'll share with him which of 2 options are better in preparation for that kind of work at home.
Great, thank you. And those are all the questions we have submitted at this point. Are there any other questions for Jasmine right now? Okay, it looks like that might be about it for today. If anyone has any additional questions, they are welcome to submit them by email. My email address is on the last slide here. We'll be taking questions up until March 25th, and we'll have answers posted on the website in early April. Thank you, Jasmine, and thanks to everyone for joining us today. And we really appreciate all your answers and taking the time to be with us here.
Yes, it was great. Thank you for having me.
Yep, thank you.